Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com. Okay, everybody, welcome back to the DaVinci Hour podcast. I am joined this week by Professor Banja at Emory University. John, thanks for joining us. Happy to have you here.
My pleasure, Maxwell. Good to be with you.
Awesome. So before we dive into it, maybe give the listeners a little bit of background on your, professional career, your research interests, your professional interests, and kind of how that's led up to what we're talking about today, which is some ethical issues with AI and how AI will be looked at in the years to come.
Sure. So I originally wanted to get a doctorate degree in philosophy. My career plans were just to be a philosophy professor at some college or university and talk about Aristotle and Plato for the rest of my life. Didn't work out that way. I was not able to get a full-time position in philosophy. Got a lot of part-time jobs, but no full-time. And I wound up at a little Catholic college called St. Francis College, now St. Francis University. And this was in the late 1970s. And I was running a program called Upward Bound, which still exists, by the way. It's for low-income high school students.
Oh, wow. Okay.
And but I really wanted a career as an academic, as a professor. And they were starting at St. Francis College a physician assistant program. And they wanted someone to teach medical ethics. And after about 2 years of a fruitless job search, I decided that I'd better retrain. So I volunteered to do it. And I think when I was in graduate school, I don't think I ever read a single article in medical ethics. So I volunteered to do it. I'm reading these articles along with the students. I'm teaching this course. And that was my foray into the world of medical ethics. And goodness gracious, the Karen Quinlan case. And by the way, you can't talk to medical students today about Karen Quinlan. They have no idea who she is. That Karen Quinlan case occurred in 1976. So this was pretty progressive for St. Francis College to want someone to teach medical ethics. So I did that. And then I went to a rehabilitation hospital in Pittsburgh, the Harmarville Rehabilitation Hospital, in 1981. Again, not with any full-time employment in philosophy. I was working in the education department, but this was a rehab hospital that specialized in neurological rehabilitation, stroke and brain injury and spinal cord injury. And I realized that there were lots of ethical issues going on there. And I stayed there for 2 years and got to Emory in 83. And by the time I got to Emory, I started to write some stuff on ethical issues in disability and acute neurological rehabilitation. Emory was very, very kind to me. And I started to meet people because in the early mid-'80s, that's when bioethics was starting to happen on the Emory campus. John Stone, Kathy Kinlaw, and those folks were ramping up bioethics, and I managed to meet them and join them in their efforts. And I joined the Ethics Center with a part-time position in the early 1990s, and then I joined full-time in the year 2000. So for about half of my career, I was teaching just kind of bread and butter courses in bioethics, talking to students, medical students. We have a doctorate in physical therapy program at Emory, teaching those students about, informed consent, privacy, confidentiality, managed care, end of life, all that kind of stuff. And then around the year 2000, I remember I was giving a lecture at a medical conference on empathic communications. I was very interested in difficult, emotionally painful communications. And I heard a speaker, Richard Cook, right after me. give a talk on medical errors. Like I say, this was around maybe it wasn't even 2000 yet. Maybe it was 1998, 1999. And I was absolutely mesmerized by this talk. I'd never heard about medical errors and how they happen and all that kind of stuff. And here I was in the audience, and I'm interested in conducting emotionally painful communications. And I'm thinking to myself, holy smokes, when a physician commits a medical error, I mean, do you disclose that to the patient? That's got to be one of the most emotionally wrenching, painful experiences, especially if it's a serious harm-causing error, that you can have. So I started to read the literature. I was incredibly lucky to join a grant effort by the Georgia Hospital Association. They applied for a grant to the Agency for Healthcare Research and Quality, got it. And for about 3.5 years, I was reimbursed 50% of my time by this grant to just study medical errors, write about them, travel across the country and talk about them at medical conferences. I mean, it was a scholar's dream, for heaven's sakes. And that's what I did for about 2 decades. And then around 2016, 2017, I'm starting to read about this AI stuff. And this was kind of a natural segue because AI is being touted as, well, it's going to be better than human beings. It's going to reduce error frequency and error severity. And by the way, if you're a medical student and you're thinking about a residency in radiology, you're absolutely nuts. You need to have your brain examined. This is, like I said, 2016, 2017. And that's how I got into AI. And that's what I've been doing the last 5 years, studying AI and all of its twists and its dimensions. So I've been at Emory now for 40 years, and it has just been a wonderful experience for me. I'll tell you, I have had very, very few bad days. It's just been a great ride. I've been blessed.
That's awesome. I mean, that's a fascinating kind of journey, if you will, to along. Yeah. I mean, as you know, healthcare is ripe with ethical dilemmas and issues. And it's fascinating how you've kind of made your way through kind of, it almost seems like the full gamut in a way. And then now and what's interesting is you've always seemed to kind of be on the cutting edge of that, if you will. And even obviously displayed most recently by, looking at AI and its future even concerns, if you will.
Yeah. I constantly remark to people that there's never a dull moment in what I do. I mean, there's always some this remarkable thing that comes along. I'll tell you that medical errors have kind of, what would be the word, kind of diminished in terms of their grip, their hold on healthcare delivery systems, especially 20 years ago when I got interested in around 2000. For those first 10 years, I was traveling all over the United States, giving lots and lots of talks. And the last 10 years, things have kind of calmed down. And then what happened? The Redonda Vought case happened in Vanderbilt, and I'm talking to a lot of my radiology buddies right now, and they're talking about how that case has had quite a chilling effect on them. I mean, something that we might talk about, you might talk about in a future podcast is I'm interested in how radiologists, because they get sued fairly often, see that oftentimes the environment in which they work is a hostile one. There's always somebody looking over their shoulder, look at that plaintiff lawyer looking at that error. Is this an error? Might that be an error? And so this Redonda Vought case, where this nurse now was prosecuted for a criminal act, not just something in tort, but a criminal act. My radiology colleagues are telling me, John, that is going to put quite a chilling effect on a physician, on a clinician's intention to be truthful and honest with the patient, especially when an error has gone down. And I kind of think they're right. I think, this is going to rekindle the emotions around medical errors and how you folks are going to handle them.
Yeah, no, that's interesting. I'm curious, you spent a lot of time on medical errors. Was that always in radiology, or were there other areas of medicine as well? Like obviously, I mean, surgical
they're
errors,
just all
like,
over the place.
Yeah.
But the thing with radiology, I mean, it seems to me that radiology is the diagnostic heart of a hospital. or a clinic, I mean, and consequently, and so many errors are of a diagnostic variety. And when you think about it, it kind of makes sense, because when you make a wrong diagnosis, whether it's the radiologist, whether it's the internist, whomever it is, that's a kind of an upstream error when you think about it, because it will then follow the patient through his or her journey through the healthcare arena. And if that diagnosis is a wrong one, boy, it might take weeks, it might take months, it might take years before that original diagnostic error is discovered and things are set right. And of course, sometimes they're not set right because you've lost that opportunity to go in and fix that disease entity early on. And now, months, maybe years have passed. I mean, in your work, the typical instance would be the missed mammogram, right?
Mm-hmm.
The missed lesion. You didn't pick it up the first time. The patient comes back 2 years later. Holy smokes, there's a big lesion there. You're curious. No way that lesion could have gotten so big in a year or two. You go back, you look at the earlier mammogram. Holy smokes, there it is. Do I tell the patient or not? That's a tough one. I mean, ethics would say, of course you do, of course you should, but the practical reality is much more difficult.
Yeah, definitely. I imagine that couple of things there. I think one, I imagine the ethical concern, and then obviously what you said is the practicality. I definitely want to talk about that with you in a second, but I think I would just comment as far as radiologists go, it's interesting, even though we don't have the patient contact, like direct patient contact that many other specialties have, we do play a surprisingly very integral role in the, not just the diagnostic aspect, but then the management, what you do from that, like you said, like if you don't see any, on a mammogram, if you don't see anything, then it's, assuming there's nothing else you're watching, then it's, you follow your annual screen and you will see in a year kind of thing. Unless the woman notices something in the interim. And, these are critical and these are people's lives. These aren't, just kind of academic exercises, if you will. And so
absolutely.
I think you hit on some really important points there. I'm curious how do you handle, and maybe it's a case by case basis, but what's ethically or what you supposed to do. And then obviously there's these, unfortunately, as in healthcare, and as we'll probably get more into in a minute here, is there's a lot of players involved. There's the hospital, there's the providers, obviously, there's the insurance companies or the payers, whoever that is, whether it's Medicare, insurance, things like that. And then, any, medical equipment suppliers, all those types of things. I guess, how do you, in your view, navigate that, if you will, in certain situations?
How do you kind of apportion out that liability when you have so many players? I'll tell you, and I know we talked about this antecedently, and with AI, that's going to be one heck of a problem. Because if you get a bad outcome and there was an error that happened somewhere along the way, my God, you got the hardware manufacturer, you got a half dozen people who are putting the algorithm together, you got the people who compiled the data training set, who curated it, then you got the hospital who have to maintain the system, and then you got the radiologist, and you have all of those folks. I mean, figuring out who's liable for what, and I know we're going to talk about this in a couple of minutes. I mean, that could be a heck of a chore. Let me tell you, though, that coming back to, like I say, this atmosphere of hostility that some of my radiology friends have told me about, if we're going to meet that head on, and if we're going to try to do what's right by the patient, and if we're going to practice patient-centered care, and if we're going to be ethical and transparent, I will tell you, you absolutely need an organization that's going to stand behind you, that's going to support you, that's going to inform you as to how to navigate that very difficult conversation that you're going to have with that patient or family. And like I say, who's going to support you every step of the way. Because if you feel that your organization is just going to hang you out to dry, it ain't going to work. It's not going to work. I mean, the incentives will all be lined up on the side of concealment. So, that I think it really starts there. It starts with an informed, ethically committed organization, risk managers can be your best friends, really, in something like this. Although the risk manager does not want to accompany you when you go into that room to talk to that patient or family, maybe better to have a chaplain, maybe to have a social worker or somebody who's good in empathic communications or something like that. But I must say, Maxwell, that when I talk to our medical students at Emory and I show them scenarios, here's this error that went down. Would you tell the patient or not? God bless them. I mean, 99% of them say, yes, I would tell them. Now, whether they actually are going to do that, when they're attendings, I don't know. But at least that says to me that they're being trained in an atmosphere of transparency and patient-centeredness. And they know that if I lie, and holy smokes, if the lie is found out, that will have ruined the therapeutic alliance. And interestingly enough, at least now, I've been teaching this now for at least a decade, medical errors and stuff to our medical students. They are of very good will. They are really patient-centered, and they are into honesty and transparency. God bless them all. And it says something really great, too, about our contemporary medical environment, because I'll tell you, 30, 40 years ago, when I got into this stuff, the physicians were told exactly the opposite. Do not disclose an error. Do not apologize. In fact, don't even talk to these people. If an error went down, have them talk to our hospital lawyer or our risk manager or something like that. It was just totally different. That was an atmosphere of concealment, as opposed to what we're experiencing today.
Yeah, no, I think that's an interesting change in healthcare that you comment on, because I think healthcare, as used to be much more paternalistic view, if you will, or was the doctor was always right. You always did what the doctor said. And now patients are becoming, much more involved in their own care, and, much more like participants in their care, if you will, than just, following the doctor's orders. And so, disclosing, what happened, that's kind of maybe part of the symbiotic relationship, if you will. That's kind of how the physician patient relationship has evolved. And it's funny you say, I remember a story. It wasn't so much an error, but I remember in medical school, I believe it was, I was, on a rotation and observing a cardiac surgery, and a patient coded on the table before they even really got anything going. And I remember they did, compressions and everything, and they brought the patient back. Thankfully, we were able to start the procedure. And so really, did the procedure went fine. So at the end of the day, at least in the short term, from what I saw, is there was no direct harm done, if you will.
Right.
But I remember very distinctly the cardiac surgeon sitting down with the family and telling them exactly what happened, and being very upfront. This could have been, could have gone a much different way. And he goes, especially if, what he was very candid about was, thankfully this happened in the OR, which is kind of interesting. He goes,
optimal code situation.
Right. If this had happened out, at home, he goes, you probably wouldn't have made it. And so, which I just thought was so interesting, because he could have easily concealed that. He could have easily just kept that, either just documented what happened and not really told the family about it. But I think I could tell he felt like a moral obligation to tell them that had actually happened. It
also speaks to what you just said about the informed patient, because lots of patients, they will request their medical records. And, if they read that OR note and see, holy smokes, I went into cardiac arrest for God's sake in the operation, and he never told me,
Right.
I mean, they might have another heart attack. So, you don't want the patient to be surprised,
Sure.
And I mean, even if you don't have a moral molecule in your body, that possibility that they might find this out, and you don't want them to find it out on their own. You want to be the first to tell them that. That's something that every physician should appreciate.
Sure, definitely. Before we really get into it, I want to just give you a chance to tell the listeners about, you have your own podcast, which I've listened to.
That is really right. Yeah.
So maybe tell us a little bit about that podcast, how you got started doing that. I know you've had, you won a grant for it, which is really commendable. And I congratulate you on that. It's awesome. And kind of what your mission has been with this podcast that you've developed.
Yeah. So your colleague, who is now taking over the chairmanship at the University of Mississippi, Rich Duzak. Rich and I got to be buddies about 5 years ago. And Rich called me up once and said, John, there is a foundation in Grand Rapids, Michigan. It's called the Advanced Radiology Services Foundation, and I have gotten some money from them. They're a kind of a progressive entity that likes to think about what's right around the next curve. They especially are interested in healthcare policy. And, I think if you would write a proposal and maybe talk about what you're interested in the intersection of ethics and artificial intelligence, tie it into radiology. I think they might be interested in it. So that's what I did. And lo and behold, they gave me a very nice grant. And so what I have been doing with that money is I set up, one of the things is I set up my own podcast page and have interviewed a lot of luminaries in the field. I've interviewed people like Melissa Chin and Bib Allen, Geraldine McGinty, Mike Bruno, Carolyn Meltzer from your own department. So we're interested in talking about, like I say, ethics and AI and radiology. Chuck Kahn, I should have mentioned him as well, because I just thought that one of the ethical areas that I'm very interested in is implementing these technologies into the hospital or the clinic. I mean, when you decide that some model has gotten good enough that you're going to integrate it into your own radiologic workflow, that's not going to be something that you can do over a weekend. So, I mean, there are all these considerations about how good that model needs to be, what kind of contractual relationship you're going to have with the vendor, especially when it comes to liability issues, and then, upkeep issues, upgrading the algorithm, and all these kinds of things. So there's a lot of, I think, ethical issues there. So at any rate, we explore those kinds of issues. Right now, I'm very interested in how the hype that was swirling around 4 or 5 years ago, again, where you radiologists are going to be out of a job, blah, 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 how that has not materialized at all. As a matter of fact, a lot of the literature that I've been reading over the last 12 months has been directed to exactly that. How come this hype has not materialized the way it has? As a matter of fact, what we're finding out is that it's much, much more difficult to develop these algorithms such that they're accurate and generalizable. Much, much more difficult than we thought. So I think from what I'm reading that radiologists, even the computer scientists, are saying, I don't think it's going to be for at least another 5, maybe not another 10 years when we start developing models that are going to be as good as the Dr. Coopers of the world are now. So I think you guys are safe for a long time. So I'm interested in that right now. How come these models are not as accurate, are not as generalizable as we thought that they were going to be 3, 4, 5 years ago? So like I say, Maxwell, there's just never a dull moment.
I'll echo. I've listened to some of your episodes, and you certainly have some of the giants in the field of radiology. That's for sure on there, and some of the, I think, cutting some of the leading minds, if you will, in both radiology.
Yeah, some of the movers
AI.
and the shakers.
So I recommend everybody out there with any kind of interest in AI to take a listen to it for sure. Podcasting it's a great way to get involved with these people and then also get their opinions. So that's awesome.
It's a great way of networking. I mean,
yes,
it's a great
absolutely.
way of leading some of the leaders in the field. And of course, I learn a lot too. So I guess the great problem with podcasting now is there's so doggone many of them out there. Everybody's doing a podcast. So
absolutely. So kind of diving into it a little bit, we're also for the listeners, and we'll put the link for this as well. Your paper in the Journal of American College of Radiology, or JACR. It's a great paper. I recommend folks check it out. But I think, you talk about when the ethical dilemma of when AI does reach that point of outperforming the clinician, if you will. And I think specifically you focus in on radiologists' ability to, identify pathology and diagnose it, and then make management recommendations based on that. I guess I'm curious, first off, how do you look at when when it's able to outperform the radiologist? Is there tiers to that? Is it, maybe, they're able to identify the more obvious pathology that, the junior radiology resident could identify versus like, they're more, or they're able to, reach that tier of outperforming in the sense of identifying the rare, very complex pathology as well.
Right. So, so the way I see it, and that's a great question. The way I see it, number one, we're going to have a baseline of error rates among the ordinary, reasonable, prudent human radiologists. Going to have some kind of baseline. What's your error frequency? Because we're going to have to compare how well the AI does with that sort of thing. And then once we have that, I would imagine the first metric would be, well, actually, our mammography AI, because they're all going to be specific, right? I mean, one's going to look at mammograms, another one's going to look at glioblastomas, another one's going to look at COVID lungs. They're all going to look at some particular focal entity. We tested our model, and it's just as accurate, if not more accurate, than the 50 board certified radiologists that we recruited. So, all right. So then we have that. Now, I think your question is really interesting then in terms of, let's say we're going to look at a bunch of routine screening mammograms. Now, we know that 98% of them are negative to begin with, right? So what are we going to do when the algorithm says, Dr. Cooper, I have looked at all this big batch of screening mammograms that you're supposed to look at today, and I've prioritized them. So this batch over here, I can tell you with 99.99999% confidence is true negative. Absolutely. In fact, you don't even have to look at these. You don't even have to look at them. Now, these other ones, these look kind of peculiar. You need to look at those. And these right here, you really need to look at these. So I have a hunch, we're going to see your work being prioritized. And, if it really comes out, if these models are going to be as accurate as we hope they are going to be, I hope that will be a boon for you, because it's going to save you a heck of a lot of time, especially on that maybe 40-50% of those routine mammograms they're true negatives. You don't have to look at these at all. That's going to be an enormous time-saving element for you. What I worry about, though, is that AI is going to open up radiologic services for the rest of the world. The rest of the world, so many people not having access to good radiology services. I mean, I'm talking about on the other side of the world. So I'm wondering if, on the one hand, you might say, well, that'll free my time up to look at these significant images, but are you just simply going to find your own workload dramatically increased because now we can send you images from all over the world, for you to look at. So I kind of worry about how your own time is going to be measured out, and whether you can enjoy your work or whether you're just going to be overwhelmed by it. So, but that's how that would be my looking into the crystal ball right now, that it's going to be, AI is going to help prioritize your work, and hopefully it's not only going to reduce error frequency and error severity, but if it does, it should reduce malpractice litigation, which should translate into reduced medical malpractice insurance premiums for you. So that's the hope. Fingers are crossed. That's the hope.
Yeah, no, definitely. I think you hit on some really important points there. I think, I had Dr. Hari Trivedi on the podcast a few episodes ago. And, for those of you listeners that aren't aware, didn't catch that one, he's a, emergency radiologist here at Emory, but also heavily involved in AI research and developing, databases for developing AI algorithms and things like that. that he runs with Dr. Judy Gachoya, who's a IR physician and also informatics and an AI expert as well. And he talked about, it was an interesting comparison he made with adopting AI. And he talked about what you're referencing when people said that it was going to replace radiologists and what's the point of training radiologists anymore. He likened it to back when, radiologists read actual real film, films that they hung up in the reading room and things like that. And he said, there were radiologists who adapted with the new electronic PACS and with the new electronic images, and there were ones who didn't. And so he likened it to that, where AI will kind of be more a tool we use, just like how electronic records are, a tool we use, not so much replacing us. But he did mention some of the things you're talking about, where it'll maybe help us cut down on more arduous tasks or, mind numbing, if you will, or more monotonous tasks, if you will, that to help and really help, like you said, reduce errors, not just, make our job maybe more enjoyable, or easier, but also to help, and more importantly, make sure those aren't missed, or things that, because we're all human. We can get tired, we can get, fatigued or rushed for some external pressure for some reason, and unfortunately miss things, as you mentioned, time to time. So hopefully AI can help with that.
and if it does play out the way we're describing it, the worry that a lot of radiologists have about the de-skilling phenomenon, in other words, that your own skills are going to erode as these models get better and better and better, and they relieve you of so much of the workload, that won't happen. As a matter of fact, your skills should get better, because you're only going to be looking at these problematic images, and that should sharpen, your own critical scrutiny and your acumen. So, I mean, your work might get much more interesting, given that.
Yeah, no, I can agree. I mean, I think one of the benefits of training at Emory is we see a lot of complex, but we see a lot of kind of bread and butter pathology, but we see a lot of very complex pathology, as you know, and so that I think definitely makes the training experience certainly much better. So yeah, I would echo that for sure. And I could see where more of our time would be spent on those more complex cases that need maybe a little bit more attention.
Right.
So yeah, no, I think that's a great point. Start us off here, maybe with a scenario. It's similar to what you talk about in your paper. So let's say, an AI model is able to, identify small, pulmonary nodules or small developing tumors at or better the rate of the average radiologist. Let's say a patient has a small thing, it's a small nodule, it's not detected by, the AI algorithm, it develops into cancer, like you were talking about, on a follow-up form. Kind of maybe dive into who is liable and kind of what's at play. Because like we were talking about, there's the AI algorithm, or you should say the maker.
Yeah.
You could say the coder is maybe liable. You could say the people who ran the trial, to give FDA approval. It's in a way, there's many different parties involved, and then obviously the radiologist, if you will.
Yeah. So the scenario then, and we have to be careful about the scenarios, because different scenarios result in different kinds of litigious approaches. So in this particular scenario, you're saying that the model missed this particular lung nodule, let's say. Yes. Okay. So if that model is up to virtually a standard of care kind of model, and if that model is a second or a first or a second read for you, and let's say you missed it too.
Mm-hmm. Yeah.
Let's just say you missed it too. So there's two misses. The fact of the matter is, I would think, be interesting to get a plaintiff lawyer's opinion on this, by the way, but I would think if you and a standard of care model both missed this lesion, you know what? Maybe God would miss that lesion too, for heaven's sakes. And if that's the case, we are not, despite how you guys feel, I know it, I get it, despite how you guys feel that you're under a kind of strict liability standpoint where you got to detect everyone, you have to be divine, you have to be godlike. As a matter of fact, that is not what the standard of care requires you to be. The standard of care simply requires you to behave at a competency level that an ordinary, reasonable, prudent radiologist in like or similar circumstances would perform. That's it. So there you go. You missed it. The model missed it. I think that you would have a considerable defense there. Now, Maxwell, things get interesting when the model says, you know what, I think there's something here, something that you need to look at. You look at it, you say, nah, I don't think there's a, and we go according to what Dr. Cooper recommends, and there's a bad outcome. The interesting thing is going to happen when you disagree with that model, right? So in my case, the model says maybe you should do X. You say, nah, I'm not going to do X. You're wrong, and you have a bad outcome. Patient can sue you. Patient can simply say, hey, this model obviously knew something you didn't, right? Yeah. So and you should have gone with this model. On the other hand, take the alternative case. Again, you disagree with the model, but even though you disagree with it, you're going to comply with what the model tells you to do, right? Mm-hmm. And there's a bad outcome. Patient's going to sue you again, right? The patient's going to say, do you mean to say that you left my medical fate up to a machine? You know, you're a human being, doctor, and blah, 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 right? So the patient can get you actually either way. So that's, I think, Maxwell, that's what we're going to have to think about. Fortunately, we got some time to think about it because we're nowhere near importing these models in a clinical treatment capacity. We're nowhere near that yet. So we got some time to think about how we can protect your liability, especially in instances where you disagree with the model and unfortunately there's a suboptimal outcome.
I think you make a very interesting point. You know, standard of care doesn't mean perfect.
Right.
You know, it's not.
Absolutely right.
I think that's important for people to understand. You know, when a radiologist graduates, you know, residency, and now, you know, most of us do fellowships. When you graduate residency and fellowship and you become board certified, that doesn't mean you're 100% of the time, you know, going to catch every single thing and every single diagnosis. So I think that's one important point, you know, that these models, if they make the standard of care, they're not going to be perfect. They're not going to catch every single possible diagnosis. Maybe they will someday, but at least I imagine the initial ones we use in this type of way we're talking about will probably not be quite that perfect at that level. So I think that,
you know, I think sometimes we're too hard really on our AI models. You know, we're going to expect them to be perfect. They're not going to be perfect. So, you know, how much error are we going to allow these, you know, these models? Only time will tell. That's one of the very interesting things, by the way, about watching AI develop, because we're going to meet up with a lot of these challenges, bumps in the road. You know, how accurate does the model have to be? And as you said earlier, when there is a bad outcome, when maybe there is an error, how are we going to apportion out liability among all of the parties who might be responsible?
No, definitely. And I imagine, you know, obviously time will tell. And I think from what I understand at this point, it'll be similar to the screening or approval process that, you know, medical devices undergo, maybe not quite as stringent, but especially as like a pharmaceutical drug. What I was thinking about this when I was reading your article is an interesting scenario would be, you know, you hear about these drugs that get approved and they go off into the market, and then years later they find that there's this catastrophic side effect that they caught, you know, maybe it causes severe liver damage and they didn't pick that up in the initial clinical trial. In your thought, if there's an AI algorithm where, you know, everything looked great and maybe 5 years out we find that it's missing all of these critical findings that we should have, that it, you know, and we're letting it essentially run on autopilot, if you will. I guess, what's your thoughts on those scenarios?
Great question. And that's another one that's on the drawing board. I mean, who knows how that one's going to play out? Obviously, again, if we're talking about a model that's going to be as good as you, that is to say, that can even substitute or replace you, that's going to be a class 3 medical device as far as the FDA is concerned. That is to say, they are going to vet that device, look to the vendor, look to the creator, and place it at the highest level of scrutiny, precisely because they don't want that to happen. let's say then that the device has jumped through all of the FDA regulatory hurdles. It's approved, it's out there, and indeed, as you say, 5 years, 2 to 5 years down the road, it starts messing up. And by the way, that's not all that unlikely, because when you think about the fact that maybe I developed the model, I developed it with my own technology, with my own imaging equipment, and it's slightly different, from the imaging equipment that you have at Emory Hospital. So there's room for a glitch there, right? I mean, and I kind of think that's going to happen. Those variations are going to happen. But at any rate, it's not performing, let's say, according to Hoyle. Well, then how are we going to handle that? And that's some of the things that we discuss in our paper. One way of handling it, by the way, is is what the developers of the diabetic retinopathy model did, the IDXDR. So this is a model that is really intended for primary care offices. It looks at the patient's retina, and we're really talking about patients with diabetes, looks at that retina, and it will make a recommendation as to retina looks fine, or, you know what, I'm seeing something there. And you, primary care doctor, you would be well advised to refer this patient to an ophthalmologist. What that company has done is they have assumed liability for any errors that model makes. So presumably we're talking about the false negatives here. If that model says this retina looks fine, and it turns out that it's not fine at all, the company, the maker of that model, is assuming liability for that. By the way, that's going to be especially the case if you have these black box models. If you can't look into that model and try to figure out how that model came to the output or the decision that it did, if that's opaque to you because it's a black box model, then it would seem to me to be only logical that you'd want to put all the onus and the liability on the model designer or developer, because it's just simply unfair to unload the liability on the doctor if you can't interrogate the model and figure out, well, why did the model make this error, make this mistake. But really, what's going to be so fascinating for me, probably anxiety provoking for you, is to watch how these liability issues, these errors, these things are going to play out, because there can be lots of these glitches, these bumps in the road as we move toward full implementation of AI 5 years, 10 years, 20 years down the road.
Yeah, no, definitely. I think that, the adoption of it is definitely going to be, I think we're going to have to let some level of error happen.
Yeah.
If you will, or I guess not allow, but anticipate some level of error to happen. And I think it's thinking about these scenarios, I think, are interesting because, obviously we deal with this with medical devices and pharmaceuticals all the time, like we were talking about. I guess, you make up a great point about the black box, in the sense of, I feel like it almost ethically, we should hold the, developers of these models accountable to that, where, to get this approved, we need to know how this works. Because if, obviously if one of these errors happens, we need to be able to go
Absolutely.
back and see, what happened. I mean, that'd be like approving a medical device, without really understanding how it works, or a pharmaceutical drug which I guess does happen in some scenarios. If you have, you hear those scenarios of cancer wonder drugs that, wonder drugs in quotes, where, they cure, they, significantly slow progression of disease in patients, and it gets this fast track approval because, many cancer patients unfortunately are desperate for, some type of effective therapy. But then, as we all know, there can be consequences of that in the end as well. And so I think it'll be really interesting to see.
It is going to be interesting because these neural networks, man alive, they're so complicated that even if the model can explain itself, I'm not so sure that we're even going to be able to understand the explanation that that the model gives for us. I mean, that's possible. So it's going to be like everything else in healthcare, and or rather in research and development in healthcare. It will be pragmatic. It will be experimental. It will be trial and error. And that's what makes it so interesting. It makes it so human. But yeah, there's always that element of risk. I mean. And AI, they talk about the fourth stage of the Industrial Revolution. We started out with water, and then we went to the steam engines, and then we went to electricity, and then digital, and now we're in this last stage of AI. Yes, we will see how all of this plays out.
Yeah,
you definitely will. Your children will. I won't, but you will.
I'm curious on your thoughts on. I was listening to a podcast recently when they were talking about AI, and they were actually talking about it making a dramatic impact in primary care, actually, because they were talking about how, which is I just have seen firsthand from just doing rotations in med school and intern years, that primary care is very arduous in terms of chart review. You have to review a lot of medical records, and spend a lot of time, following lab values and things like that. And what they say was an interesting thing is a lot of times you only have time, like if you're following a patient's, lab value, you maybe only look at the most recent or maybe the most too recent, but they've got 20 over the course of time. And, using AI models to go back through the charts, like what you described for radiologists at the beginning of the day, maybe it runs overnight, you come in the morning, you say, oh, maybe you should pay more attention to this particular patient's lab value, or this particular patient keeps complaining of this certain symptom or things like that, or physical exam finding. I guess, how do you see maybe some of that playing in if for example, it says, oh, you should pay attention to this and not, do you see it being very kind of the same principles carrying over, or do you see maybe new dilemmas as well playing into that?
Well, if you believe the hype, if you read the hype, given AI's extraordinary capacity to ingest data, presumably when my grandchildren go to their primary care provider 30, 40 years from now, they're going to put their medical card in a computer, kind of like the way you and I put our credit cards into the gasoline tank, when we go to fill up. And presumably, not only your whole medical history is going to be on that computer chip, it's going to be your family's history, it's going to be your medication history, it's going to be everything is going to be on there. And the machine will take your presenting symptoms, and it's going to run through PubMed, and it's just going to filter and examine and compute all of this data, presumably in a way that absolutely no human being can. This is the great promise of AI. Whether it actually is going to play out that way a century from now, who knows? But again, its ability to compute just enormous volumes of data, we will see whether or not that has the kind of impact on healthcare improvement that we think it should. Maybe it won't. I don't know. Maybe Dr. Welby, and again, you can't talk to third-year medical students about Marcus Welby. They don't know who he is. Maybe that kind of intuition. That is an interesting topic. So I just got done reading a book called The Myth of Artificial Intelligence by a guy named Larson. And he makes a very interesting point about how AI does not think the way you think, the way I think, the way Marcus Welby thinks. In terms of AI doesn't have intuition. It doesn't have hunches. It doesn't play its hunches. And consequently, when a patient starts presenting to a veteran doc, and his or her mind starts computing, starts listening to, and all those neural networks start going, what could be going on here? What could be going on here? And you just kind of get this hunch or this intuition that, I think we should order this particular, I just think we should do that. And holy smokes, a lot of the time you're right. That's just it's a real revelation. Well, AI is not going to be able to do that. So, and that's the point that Larson makes. So it's he's saying that AI is going to be so different because it thinks differently. Also, an interesting flip side of that is when AI makes an error, it's not going to be like a human error. It's going to be a real whopper. It's in some instances, it may be absolutely hilarious when the model makes an error. But all of this is going to play out in the wash, and we will. Who knows how it's going to play out now. Whether all of that data will be important, significant, revelatory, or not. And by the way, the models might teach us some things that we don't know. We might have discounted for decades the importance of, for example, air quality. The importance, the significance, or the correlation of air quality with a patient's health status. Models might tell us about how important that correlation is.
Sure.
Yeah.
Well, one scenario I wanted to ask you about, because you bring it up in your paper, and correct me if I misquote this, but you bring up a scenario where I think it was a stent device or some type of medical device that malfunctioned, and the patient actually sued the device manufacturer. Right. As I guess, and I thought it was interesting how you discussed that. And I think if one of these errors happens with an AI, maybe summarize that a little bit for us, how that played out, but then also how that would apply to if someone sued the actual developer of the AI algorithm in that scenario.
Right. So what? I happen to have my paper right here, and I can quote the case for any of your listeners who are interested. So this was the case of, let's see, it's footnote number 23, the case of Regal, RIGEL versus Medtronic. Medtronic was the maker of it was a balloon angioplasty device. And this case went down in 1996, I believe. And just as you said, the balloon malfunctioned in Mr. Regal's heart as he was undergoing coronary angioplasty, and resulted in Mr. Regal needing additional surgery. It was pretty bad. So the Regals sued Medtronic. Medtronic, however, had gotten a pre-market approval. That's what it's called, a pre-market approval from the FDA on their angioplasty device. And what that pre-market approval allowed Medtronic to do was that any litigation that was initiated by an aggrieved plaintiff would not go into a state court. It would be heard in a federal court. So the litigation was exempt, actually, from tort litigation occurring at a state court, and it was referred to a federal court. Now, if you're a plaintiff lawyer, you don't want that to happen. And you don't want it to happen because traditionally federal courts are not as sympathetic with the plight of plaintiffs like Mr. Regal as our state courts. So you want to get your case heard in tort litigation in state court.
Why is that?
It's because, and again, you have to be a lawyer to appreciate this. It's that the evidentiary rules are a bit different in federal court. The perception among plaintiff lawyers is that the recovery, if in fact the plaintiff does recover in a federal lawsuit, they don't get as much money. The perception is that federal courts tend to be more friendly toward corporations. They tend to grant their motions a lot more than they grant motions for the plaintiff side. So it's just a bit more challenging to try the case in federal court. And that's a big issue, because obviously the first step that you got to do as a plaintiff is you got to get a lawyer. Sure. And if that AI device, and here's where we're coming from, the thinking is that if that developer gets that pre-market approval, that FDA pre-market approval on his or her device, you have taken a giant step to protecting your liability. on that, so that even if you do get sued, and even if the plaintiff wins, he's not going to get all that much money as if he had prevailed in state court. So, I mean, that's just one legal strategy that device manufacturers might use to mitigate their liability. And there are going to be all kinds of these, legal maneuverings, clearly, that the device manufacturers are going to use in order to further their cause, protect their product, and to protect their revenues. So yeah, when I came across that, I was really stunned, because you would think that Mr. Regal, holy smokes, this thing malfunctioned. This is a slam dunk kind of strict liability case. Here you go. You sue Medtronic, their device screwed up. It wasn't that easy. Wasn't that straightforward.
Interesting. Do you happen to know, was the physician named in that as a defendant in that case as well, or was it strictly just Medtronic?
I don't know. But the lead defendant was Medtronic, and
Gotcha.
They prevailed. I mean, their argument, Medtronic's argument was, and this is what the whole case was about. Medtronic's argument was, Judge, you can't try this case in state court. You got to try it in federal court, because we got that pre-market approval, and therefore we're exempt from these particular kinds of lawsuits, and they won. So I don't know what the aftermath of that is. Maybe they settled with Mr. Regal. Maybe Mr. Regal never was able to advance his cause in federal court. I don't know what happened.
Gotcha. Kind of one of my final questions here I'm thinking of is you brought up the case of when things can turn criminal. I'm curious if you could ever see that happening with you would hope it never would, but if a physician blatantly disagrees and goes against numerous other opinions.
Reckless is the key word.
Yes, thank you. Yeah. Do you see that happening with an AI algorithm?
No, I don't. And I know where you're coming from. And let's face it, the whole healthcare world is buzzing about the Redonda case in Vanderbilt in Tennessee. And I'm not an expert on the case, but I know that Ms. Vaught actually made multiple errors there that frankly looked very, very bad. She overrode multiple times the alarm system that was going off, that was asking her, are you really sure that you're getting the Versed here? Take a look. She never looks at the label of the vecuronium. She doesn't think to herself, I've got to mix this with, I've got to reconstitute this. Versed, you don't have to reconstitute the vecuronium. You do. She never looks at the label on the vial, where she's pulling the medicine into the syringe. She does not stay with the patient when she injects the vecuronium into the IV line. So there's a whole bunch of things that she did here. So I'm thinking right now, I can't imagine an AI and a physician committing those multiple kinds of errors. But, I'll tell you, if it can happen in healthcare, it will happen. I've learned that after 20 years of studying medical errors. So time will tell. But right now, it's just hard to imagine that an AI model might land itself, its manufacturer, and its physician in a criminal proceeding. I find it impossible to imagine right now.
Yeah, I mean, it would almost be like those cases where you hear of like the airline pilot purposely crashing a plane or something like that. It would almost be like someone just purposely being, like you say, reckless.
Gross negligence, right? Gross negligence, reckless.
Right. Yeah.
And I mean, that's the whole business of the AI is to prevent something like that from happening. So if something like that would happen, I doubt that it would be the AI that would be implicated in the maloccurrence. I have a hunch it would be the human operator. But one thing that we didn't mention, Maxwell, maybe this is a good point on which to end. Will the day ever come, assuming that these models get so good that they can substitute for you? If they substitute for you, if they replace you, should I be able to sue a model? Not Dr. Cooper. I want to sue the model for it because Dr. Cooper never looked really at the film. He just took the AI's word for it, So that question is making its rounds among tort scholars. Is the day ever going to come when a piece of software becomes a person, for heaven's sakes, and you can sue it, you can go after it? But then where are the assets going to come from? Because you're obviously going to want damages. So how's that going to happen? How is an AI model going to accumulate assets that a plaintiff can go after?
No, I think that's a fascinating scenario, and I think it's there's a difference between, like we were talking about earlier, treating it as a tool versus an autonomous, if you will, in that scenario, an autonomous being, or decision maker, if you will. And it's interesting if it would almost be kind of using the airline analogy, if you will, because we tend to use that a lot in healthcare, is following the airline industry's way of doing things in some scenarios. But like if you had a plane that had no pilot on it whatsoever, I think that this kind of scenarios people have talked about.
An automobile, right? How about the autonomous self-driving cars?
Yeah, exactly. That's a great point too. That if those crash, who is liable? Is it the maker of the software? Is it the airline? Is it or in the car scenario, is it if the Tesla or one of those other car companies that's working on that, is it, that's kind of who shares the liability is kind of an interesting thought for sure.
It is. It absolutely is. But you know what? I think that in all of this, although, like we said, over the next couple of years, the road is going to be a bit lumpy, bumpy. There's going to be glitches. There's going to be, some embarrassments and all that kind of stuff. I really ultimately think, I'm thinking about my grandchildren. I've got 6 of them. I think the future is going to really be wonderful for them. I think we're going to ramp up this technology to the point where the healthcare world that they have is going to be a safe one, a very, very informed one, and an efficient one too, and also hopefully that the clinicians, the human beings who work in that world, will enjoy it and will be glad that they chose the profession that they did.
Definitely. Well, John, it's been a fascinating conversation, and again, I commend you on your podcast, and again, we'll share that with the listeners again, and so hopefully they can catch more of these types of conversations from you and your guests that you've already done, and then obviously as you continue to bring them on and have these interesting conversations. So thank you again for joining us. Really appreciate it.
I appreciate it, Maxwell. I enjoyed it. Thank you.
Thank you for listening to this episode of the DaVinci Hour podcast, presented by DaVinci Academy. Please be sure to subscribe to our YouTube channel and follow the podcast on your podcast platform of choice to catch the latest episodes. Please leave a comment or a review and share it with a friend. Lastly, you can find all of our podcasts, video courses, and books on our website, dviacademy.com. Thank you for listening.